know who's my GA nurse, and I know, and she knows what I want. So she'll have everything ready. So whenever you're called to an emergency department by your PITS colleague, you know by then it's going to be a difficult airway. If not your PITS colleague, doktor anak-anak, pasti they will already intubate. But when they call you, means they are in trouble. You have to be there prepared. And you have to know what skills they have and what skills the assistant around you have, so that you can manage the airway properly. All right. So you need to be your situational awareness have to be a bit antenanya besar dikit ya, supaya so that you can be good in managing the patient. Then I'm going to talk. Then the human and cognitive factor. You know, human, we are human. To err is human, right? Berbuat salah itu adalah manusia. So, but we need to eliminate this cognitive error, the fixation. Sometimes we are too gung-ho at doing certain things, we're fixated, and then we have delayed escalation, and then we underuse certain things. So we need to look at that, which I will talk more later. And then team factor, we need to have good communication, and we must lead in crisis. All right. So let's go back to difficult airway. So I'm not going to talk about vortex today, Prof. Unita, because I've dived into that yesterday. But this is basically like what vortex are talking about. Okay, you basically need to know that difficult airway just now was difficult mask ventilation, difficult laryngoscopy, but what they didn't mention is difficult SGA. And in that situation, you need to, like vortex says, you need to be able to move around from difficult mask to difficult SGA to difficult laryngoscopy and intubation. You must quickly move around so that you don't end up in this position, kaiko, yeah? So when you are in that position, you are deep down 6 feet under, and it's difficult to come out. So that's what vortex is about, all right? And that's more commonly used. That term is commonly used in Australia. You will see just now the paper Prof. Nita shared. It's from Melbourne. So vortex is more from Australia. When we talk about difficult mask ventilation in children, this is a study from the Pedi registry from US, and they look at their retrospective registry. It's a huge registry, and they note that factors that associate with difficult mask ventilation are neonate and infant rather than children, obviously. And then a patient with increased body weight, the fat, you've got many fat children now. Those who are also underweight, you know, those in the less than 5th percentile in weight for age, and those with the children with congenital abnormality, like those with Pierre-Robin. You've seen patient with Pierre-Robin sequence, Goldenhar and Treacher-Collins, and also children who has glottosis or limited mouth opening, large tongue. And in this paper, in this registry, they recommend that if you have difficult mask ventilation, don't hesitate. Rescue placement of supraglottic airway to improve the ventilation, okay? And the incidence of difficult mask back ventilation from this registry is about 9%. So let's say there's 100 patient, 9 patients are at risk. So that's quite a bit of a number, right? So you have to be anticipating it, okay? So, and they also said when you have difficult mask ventilation, don't hesitate. Give the muscle relaxant, okay? Because patient might actually struggling, fighting it, so it's easier to give muscle relaxant and intubate. So what about difficult SGA insertion? Difficult SGA insertion, this is an old study from the same group actually, the Pedi registry, but this was the first Pedi registry in 2016. They look into a 77,000 patient who has congenital abnormality, so already known to have a difficult airway. And they look at the elective use of SGA in management in children with difficult airway. And they said only 0.6%, which is 459, has difficult supraglottic insertion. So what is the implication? It just said that supraglottic airway is useful. It's a useful rescue airway. Difficult intubation in Europe, the Nectarine study, they noted that Nectarine is neonate and children audit of anesthesia practice in Europe. They look at 31 European countries, 165 pediatric centers. The incidence is about 5.8, yeah, of difficult airway. And it's more in infant from birth to 60 weeks post-conception, the most highest. And 2/3 of this were unexpected. The baby looked normal, but they failed to intubate, all right? And there's a lot of airway guidelines. So this is the latest airway guideline that comes out. And I feel like this one is from ASA. For the first time, ASA inserted a children part in it. And this one is from ESAC, European Society of Anesthesia Intensive Care. It's a little bit too much to comprehend, but I reckon that all of you should go back and look at it properly. Okay, read it. But I'm going to quote one paper, this paper, Management of Pediatric Difficult Airway, New Strategies Unveiled. It's from Current Anesthesiology Reports 2024. This author has put together the two guidelines, because it can be a bit confusing for us to follow, and put on a recommendation. So for the next 15 minutes or so, I'm going to base my talk on this recommendation, because I felt something is easier for me to make you understand what you need to know, all right? So let's go to the first recommendation. For intubation, they said you have to avoid multiple attempts, as more attempts increase complication. So I'll just look at this. Avoid multiple attempts. Avoid using same device. So if the first device is direct laryngoscopy and you fail, don't go do the same thing. Don't repeat the same modus operandi. Look what you can improve. Have a video laryngoscope, okay? Position your patient. Don't do the same thing again and again, because that's just stupid, right? And patient doesn't have that reserve. So to avoid the same device, avoid the same technique. If you have these children, please consider video laryngoscopy first. Children with suspected difficult airway, neonates and infant with normal airway, because they are the one that previous studies show is at risk. And if you've gone up to 3 attempts, please then they said 3 + 1. So at least one of the attempt must be using video laryngoscope, okay? And if you fail, if you still can wake up the patient, by all means, they recommend please wake patient up, all right? But if the patient is desaturating away and there's point of no return, then you have to think of something else, that is CICO, okay? So the next one is recommendation of rescue device. So if you have failed, you cannot do all those, then they recommend combining different devices. They call it hybrid technique. This will need 2 equipment, 2 skilled physician, and he has been shown to be successful in difficult airway, especially in children. So what would they do? They actually combine, we call it VAFI, video laryngoscope, with fiber optic. Actually now, what we use is not fiber optic intubation, it's flexible intubation video endoscope. It's a little bit different. Fiber optic is a little more fragile to use, but 5 is easier. So we combine this, so you need 2 person. I've done it this sort of way in my small baby with Perioperative sequence, and they are very anterior. Even using a glide scope alone, this is my favorite for children because it's hyperangulated, if you remember from yesterday. So I still cannot get into it, so I use a 5 flexible intubation video endoscope to direct the ET tube there, and most of the time it works. The only thing it can be tricky in neonate and infant, their mouth is small, so when you've got 2 hands going there, you need a bit of coordination, and to get to that coordination, you need practice on mannequin and all that, all right? So it works. And then another rescue device which we discussed yesterday was insert appropriately sized SGA early if you fail the mask ventilation and video laryngoscope. Because it's easy, right, to insert supraglottic airway. Yesterday I heard you say, oh, this is smooth, you know. And then when we put the second generation, like what we had yesterday, where in my study, I use Ambu Aura Gain, which is a second generation device. I did this in a 20 kilo baby, so 2 to 3 years children. And we can ventilate, and it gives us the opportunity to stop and think what to do next. If we've been trained to railroad ETT in it, like what we did yesterday, by all means, take the time, insert an ETT, and then you can get a good patent airway for the children. But if not, you can get extra help from your seniors, okay? Recommendation 3 is oxygenation. So oxygenation is very important. So what do they recommend? Like what Prof. Yunita has mentioned, you need to pre-oxygenate patient, okay? If you suspect difficult airway, give high flow nasal cannula. This is what we use in our center. There's a high flow nasal cannula. But this high flow nasal cannula can be quite expensive. It's about 300 Malaysian ringgit per use. This patient we charged this patient because he's from Korea. But if patient couldn't afford and it's not subsidized, what I do, I just put nasal cannula. Then I dial my oxygenation to 15 liters per minute. So that also helps passive oxygenation, okay? And it's been shown that it improves apneic time. So you have more time to actually look around and intubate rather than letting the baby desaturate fast. Okay, the next one is sedation and relaxation. You know, once when I was in my 4th year trainee in Malaysia, I was called to ER by my pediatric trainee colleague. She said, I'm unable to intubate an infant. So I ran down and I thought, oh no, my PIDS colleague called, this must be difficult. And she was struggling to intubate patient with bronchiolitis. It was a 2-3 years old child, which is not a difficult one. Then I noted she did not give muscle relaxant. Because pediatric are trained to only give ketamine for intubation. They don't dare to give muscle relaxant. So I told her, why don't you give SARS to intubate? The baby is fighting, you know. And she said, no, cannot. So because now it's upon me, I just gave saxametonium, and I was able to intubate the baby easily. So what's the moral of the story? Okay, even now, that was like what, 20 years ago, right? So what is it now? It's in the recommendation. Ensuring a good depth of anesthesia and the use of neuromuscular blocking agent increase the success of tracheal intubation. So don't hesitate, okay? It reduced the incidence of complications such as laryngospasm, because sometimes patients just go laryngospasm, you cannot oxygenate. So don't worry, okay? If you have tried and you cannot, you have to paralyze the patient and intubate. Next is the use of ultrasound. Ultrasound is not something you do in a patient who is tachypneic at that point and desaturating away. But if you have that window of period and you think this can be a difficult airway, they recommend the use of ultrasound, because you can then map where is the cricothyroid membrane, all right? So it's a good technique to learn so that you can identify the cricothyroid membrane. And in case if you need to go to emergency IFONA, you sort of know where to go to, okay? Then after all that hard work of intubation, extubating a baby is a complex, is a critical time, all right? We must treat it with respect, because at extubation, you can fail as well. So what do they recommend? They recommend that you have to elective extubation needs careful planning, risk assessment of patient readiness, reversal of muscle relaxation, and sufficient respiratory drive. You need appropriate help like what you intubate. So this is their recommendation. You need to prepare, okay? Management of anticipated difficult extubation. So it's not just difficult intubation, but difficult extubation. This is from AZAC, so you need to prepare where it must extubated in the most appropriate area, when, during daytime, yeah, when help is most abundant, and then who, you must ensure there's a presence of competent and experienced physician in pediatric difficult airway management. If you think the risk is very high for failure, you could ask ENT specialist to stand by for you. And you also have your E4NA kit near to you, all right? And then, of course, you have to have what is all the appropriate equipment and support. So when do you think the patient is ready to extubate? You must make sure that they are weaned and reversed from anesthesia, sedative, and neuromuscular agent. You need to time out. Everybody must concentrate because this was a difficult intubation. You don't want to fail second time. Okay, don't do the second mistake dua kali. Yeah? And then when you discharge the patient, you have to ensure that you have record it appropriately so that another colleague like yours who has the problem, who will face this patient, know what to do. Yeah? And the recommendation, there's 9 recommendations, I think, altogether. 1, 2, 3, 4, 5, 6, 7, 8, 9. Yeah, so recommendation number 7 is to be prepared. We must ensure we have a good airway card. So this is the recommendation. In my center, we have something similar like this, but I use DAS, we put a label, rather a picture. So we use DAS 1, A, B, C, D. So airway, A is airway, and then the laryngeal mask. So this one gives you sort of visual where to find all the equipment. And this should be a standardized airway trolley, difficult airway trolley. So when there's a difficult airway, when you just shout, help, difficult airway, push in the trolley. So your nurses will know which trolley to push, okay? And even any nurse or any person who walks in knows where to find the equipment because we need to be prepared for this, okay? And you need to update your airway card regularly. So in my center, we have one in the main building where we've got 12 theatre. I've got one pediatric difficult trolley there. And then I've got one in my pediatric operating theatre where we have 3 operating theatre there. So we have similar arrangement so that we don't have that cognitive overload, you know. We know where we are. Recommendation number 6 is the human factor. So as I mentioned earlier, we need to have good leadership in crisis, okay? We cannot be fixated to the error, to the same thing over and over again. So when we talk about human factor, I recommend that you go back and look at Elaine Bromley's story. I'm not sure if any of you have heard about it. Elaine Bromley is actually a lady who just went in for ingrowing toenail excision, okay? Her husband is a pilot. So she went in, they failed to intubate her, failed laryngeal mask, failed difficult mask, and then they called, actually 3 senior consultant anesthetists came in. All of them were fixated to get the tube in. They didn't realize that she was actually desaturating to the point she was, when they couldn't even put any tube, they woke her up. By that point, she was really, really desaturated. I think she developed hypoxic ischemic encephalopathy. So she was brain dead. And they wake her up. She was GCS less than 8, but they said, oh, she can breathe. They sent her to ICU. She died. All right? So what was the moral of the story? In between that 3 consultant was thinking what to do next, the most senior nurse said, do you want a fiber optic? Do you want a fiber optic? But everybody just shut her down, said, you don't know. Don't disturb us. They don't listen to others. So they were just so fixated. The moral of the story, don't be fixated in performing a difficult task because a study shows that physician students who engage in challenging tasks underestimate the elapsed time by 40%, you know. And then fixation errors such as focusing on tracheal intubation rather than oxygenation can contribute to anesthesia-related morbidity and mortality, all right? So don't be fixated. So that's why you need to have teamwork. You need to have a clear plan on how to approach a difficult airway. Once you have a crisis, the most senior, if can, be the team leader. You have to overlook and say, okay, switch to this, so that everybody is more alert. It might not be consultant, it might not be your specialist, it might be between you, the first year registrar, One of you have to step up and say, okay, we are here, we need to do this, we need to do this. Be able to take that leadership, okay? Don't feel that you're not adequate. You've attended the workshop yesterday, right? So you're empowered to do it, correct? Okay. Apa? Siap, siap. So I'm sure all of you are empowered to do it, okay? So this was an interesting case. If I got time, if I might share, yeah? This case was Perioperative. This patient was done in another, with a cleft palate. He was sent to another center where they couldn't intubate. They didn't expect, because he's already 4 years old, they didn't expect his Perioperative was that bad. He was in another center far from my hospital. And failure to intubate, desaturate, then finally they managed to intubate, but they couldn't do the op because it's all swollen and had to send to PICU. The mom was a dentist, she was upset, and she said, no, I want to go where there's a pediatric anesthetist who can intubate, and she actually hunted us, and she came, she said, I heard your center can do all this. So she wanted our pediatric anesthetist to do it, so I was very honored. And this is my fellow, Dr. Iftita. I was just, we had a clear teamwork, we had a clear plan what to do, and it was uneventful because we have the right skill, the right team, the right equipment. It was uneventful, and he didn't even need ICU backup for the operation, okay? So the next one is education and training. So we have to incorporate research and practice into regular training and simulation. So this is what we had yesterday, a workshop. It's nice to have, it's good. It's actually proven that clinical practice statement says that pediatric airway management requires specific skills, sets of skills and structured, and you need practice. Practice makes perfect, so you need simulation. But you cannot do this only once a year. You need to do it regularly. In my center, we do it every 6 months for all new trainees. We have all 5 to 6 stations. Everybody knows, must go through. They have pre and post tests. And we have case discussion, and we have hotspot simulation with a real case scenario. So by the end of that training, they feel more confident. And it says that it takes 1 to 2 decades for original research to be incorporated in routine practice, so simulation is a way to go. Before I finish, this is my couple last slide. When you reach can't intubate, can't oxygenate, declare early, okay? I talked about this yesterday. We need to do EFORNA with the scalpel bougie technique, where you have to do the cricoid, the incision. Okay, do a vertical incision, 2 to 3 centimeter from the skin. Okay, and then you cannot feel the cricoid all the time, cricoid membrane. Then you just do 2 to 3 centimeter, and then open up till you feel the trachea. Do a longitudinal tracheal incision for 2 to 3 rings, insert the frova, and then railroad with the tube. All right? So this one needs practice. If not, you won't have the confidence to do it in children. But in my 20-odd years of training, I've never had to do this. I'm relieved, because I think I believe with all the other advanced technique, we don't arrive here. But if we have to push to a corner, we must be able to do this. Okay? And just want to share with you the new tools that's coming up in Malaysia, and I'm sure it's going to come in Indonesia too, is this called Safe LMTM. It's now, they have a camera that goes to the LMA. So when you insert your LMA, you can actually see it directly. You don't have to put the flexible intubation video endoscope through it. It's already incorporated in the equipment. So, and it actually comes with a bigger monitor, which I'm going to use soon in one of my study. It got AI. So once they detect the vocal cord, if it runs away, the AI will correct and say if your LMA moves, they can also say, they will alarm and say your LMA moves, so please correct it. So it's good for long surgery. So to summarize, children's airway is different from adult. Recognition of difficult airway, good preparation, and familiarity with backup plans is paramount, all right? I cannot overemphasize that. We should understand the difficult airway algorithm. It's complex, but stick to one. Read, understand, stick to one, and able to apply it, okay? And then learn more about your new equipment, because like any iPhone upgraded every year, equipment are also upgraded every year. So you have to learn your equipment and train to use it. With that, I thank you.
Yes, please applause to Prof. Ina for insightful and comprehensive lecture also. Especially there are recommendations that very relevant for our clinical anesthesia practice. Okay, and then okay, then this session is for questions for discussion. So if there are questions, any again. Is there online also? The committee, please, to monitor the question from the online participants. Is there any questions? Okay, okay. Do you have a microphone? Okay. Please mention your name and also to whom the questions you.
Thank you, Doctor. Please introduce my name is Genta. I'm from semester 5. This question is to Prof. Ina. In your slide, if I'm not mistaken, I read if ventilation is impossible, administer muscle relaxants. It's contradictive from what we learn. From what we learned, it's muscle relaxant is given after the airway is secure. So, if please explain. Thank you.
All right.
I know this is controversial. This was also controversial when we discussed it in my center. We had Prof. Joseph Holsky many years ago. We had this conversation too, but it's not something I created myself. It's also in the guideline. If you look at EZAC 2024, where they come up with the guideline. Why are you you paralyzed, right? Because you already now entered the point of no return. All right, you've given propofol, you've given ketamine, and patient already desaturate, and you're struggling, and patient in emergency as it is already desaturating away. First, let's get back to the scene. A baby desaturating in emergency. Mau nggak mau, udah nggak bisa nafas ya. So then you are called, then you say, okay, I'll give ketamine or propofol. So you render the patient more unconscious. Now I ask you back, do you think the patient will wake up? No. So you only have to think, can I wake this patient up, or what I do next? Of course, you can go to put LMA, and then you try ventilate. You go through that. But if you cannot with LMA, you still cannot, then there's point of no return. You paralyze because maybe, although the patient is unconscious, but the mouth is still tight. They're still fighting you. Understand? Have you got the feeling when you don't put a good depth of anesthesia and you don't paralyze? The mouth masih ketat, nggak bisa, kan? So you paralyze. When you got paralyzed, then you got that relaxation, then you can do a proper video laryngoscopy. Then you intubate. Because you're already in the vortex, not the upper vortex, already in the middle before it go down to that bit, you know. If with muscle relaxant, you still can't, then you have to think of CICO and EFONA. Okay, so you are right, that was traditionally how we were taught. I was taught that way too. But if you have given enough, if you look, you give propofol. How long does it take for a patient to wake up from propofol? Berapa minit?
1 to.
Not long, not short, but not very long, not short. But a baby with 2 minutes without oxygenation, hypoxic, right? Yeah. Okay. I hope I answer your question.
Yes, very clear. Thank you.
Thank you, Genta, and thank you, Prof. Ina. Is there any questions? Yeah. Okay, Prof.
If you have a patient with a really difficult airway for intubation, when the real good time when you want to extubate, really in is still deep anesthesia, or when the patient is really wake up and cry, which is the better?
Okay, this is also debated in the exact paper, extubate deep or awake. It also depends on whether one, of course, you have to ensure that all pathology related to that is reversed, correct? And you have reversed the muscle relaxant propofol, then patient is ready to be awake, to be extubated. So deep or awake, in my practice, I prefer awake, all right? And if it's a very difficult airway, we will extubate in OT. Even if patient goes to PICU, then they say this is a difficult airway, let's bring it to OT. We will extubate in OT. If it was my patient, okay, from OT, we'll extubate in OT and monitor. If successful, then only we go back to PICU. So my practice, this is my own liking. I will extubate awake when patient, awake. If patient is, this is a really best practice, okay? In children or even in adult, you need to, if you give muscle relaxant, make sure you reverse the muscle relaxant. So monitor the muscle relaxant reversing. Because what is the last muscle to come back from paralysis?
Even with traumatic brain injury or even with you have hyperactive airway, what do you think?
It depends on the situation. Traumatic airway, if patient has to be extubated, they will be quite awake. The GCS must be full, right? Yeah. But if in emergency situation like laparotomy and whatnot, I will make sure that patient is fully reversed. I can use a TOF count. And then that is. If you want to use clinical sign, it can be quite masking, because you can think, oh, patient can lift head, baby cannot lift head, right? Then you say baby can flex leg. But study has shown, I was involved in this Sugar Madak study. Study has shown that flexing leg is not enough sometimes. You need to be using TOF count. So in difficult airway, I will use TOF count. I will call for the TOF count to be in my theatre to check TOF countnya 4, TOF ratio-nya 0.95. Then I know it's fully reversed. And then if I use propofol or servo, they are all wash out. Patient open eyes, crying. Extubate awake.
You still sometimes we have a patient after the operation was finished, we transfer to intensive care. Still we intubate the patient. In the intensive care, there's not completely medication or the people, the experienced people to extubate. Which one is the better? In operating theater or in intensive care? We intubate the patient.
In my center, our pediatric ICU and pediatric OT is next to each other. It's very near. So, and we work very closely with our intensive care. So we will negotiate with them if they are happy because they are also trained pediatric intensivists. So they will normally win everything with awake. They are most of the time very happy to extubate themselves, and they will tell us standby if they have problem. Okay. Now my pediatric intensivists also are good at using video laryngoscope. Before this, they don't have one. They always borrow from us, but I think the last couple of years they have also buy their own, so they are quite good at it. So what I'm trying to say, it depends on your support, backup, your surrounding. When you go to your center, you check. You must know how good is your PICU, how good. So in my center, I know they are good. So most of the time they do themselves. Unless my PICU consultant said, Ina, I'm not happy, can we come to OT and extubate, then we'll do it. But sekarang ini jarang have to do that.
You still use Sukarmatek?
Oh, yeah.
You always? You always
Not
use.
always, because sugar mother is still expensive. It hasn't been, in certain countries, it's now generic. It's cheap, you know.
Yeah, yeah,
Cheaper, not cheap. In Malaysia, it's still expensive. So in certain difficult airways, we use, yeah.
Okay, thank you.
And I
Thank you.
think it's fantastic.
Thank you, Dr. Pandit. Is there any questions? Okay, from the online participant. So it comes from Gunawan. Okay, it's our alumni, right? So he is asking, ya, mohon izin bertanya, dokter, apakah bisa dijelaskan lebih lanjut tentang Ivona, peralatan dan teknik? So he asked about Ivona devices and the detailed technique.
Okay, Dr. Gunawan, terima kasih ya di atas soalannya. Ivona in children, they are trying to mimic the adult, right? So what is also called scalpel bougie technique, SBT, scalpel bougie technique. So what you need is a scalpel, a bougie or a frova. A frova is good, or like an entry catheter, because you can have ventilation port on top of it. And then SBT, and then scalpel. Another extra thing that they have is I don't know what's the word. It's like to hold open the dilator, just to hold, not to hold open the incision. To hold open the incision is just like a dilator to open it up. All right, and then the tube. So 4 things. Okay, so a scalpel, you palpate, you do the vertical incision from your where you think you can feel a cricoid, and then just 2-3 centimeter, and then you slice through the layers of the skin until you see the trachea. And trachea in children is very small, in babies, just this big, you know. And then you just do an incision there, 2 to 3 cm, and that one you have to hold with that dilator, and then put your bougie or frova, and then put the ETT. So 4 steps. Okay. There's a good literature in the which I didn't share today, but you can look into the literature I shared. My slides people can get later. I also saw soalan dari Dr. Susilo.
Oh yeah, really?
Dr. Gunawan, I hope that explains. Okay. From Dr. Susilo, he asked about
Is there Dr. Susilo ada? Oh, wow. Selamat pagi, Dok.
because I shared with him the slide. He said it's reincarnation of intubating LMA. Actually, Dr. Susilo, safe LMA is a reincarnation of intubating LMA. I think intubating LMA it's not intubating LMA. We call it C-track. I don't know, Dr. Pandit mungkin kalau yang lebih tua daripada saya atau sebaya umur yang akan pernah lihat fast track, C-track, C-track LMA.
Yes.
Yang bayar umurnya kayak kita aja ya. Karena I think it came too early. People don't think it's useful. It didn't sell. People think it's very expensive. The technology was expensive, so many people didn't want to use it. But I'm going to publish one paper soon. It's been accepted. But in adult, you know how they teach you how to do 5 tests to think that your LMA is sitting well? That you do the sternal notch test, bubble test, Rouse tube test. It's 5 tests to test the OLP, to seek the performance and the placement of the LMA. My results show that test doesn't ensure that your LMA is sitting 100% correctly. There still be malposition. It can say it sits well, but it doesn't detect the malposition one. So it is still recommended if you can see where you go, because we drive with our eye open. We want to see the vocal cord with our eye open. So with that equipment, we can see the vocal cord and then we can intubate. In adult, there's a intubate conduit straight away, but in children, they don't have that conduit to intubate. You still have to push in another tube outside that.
Okay.
I hope I answered that, Dr. Susilo. Terima kasih ya.
But if the facilitation has no like what called TM safe LMA, do you have another alternative like use Mechil?
Previously, I just used Ambu Aura Gain, like what I showed yesterday in the workshop. We use second generation SGA, yeah, because the second generation, the airway ventilation, they are big enough to put in appropriate size tube. So for a size 2, you can put a size 4 tube, something like that. Size 1.5, you can put a size 3.5 tube. And to put that, we need an extra equipment, which like I showed just now in my study, we use we use a scope, another 5 flexible intubation video endoscope, and we railroad it with so yesterday I think the trainees had the opportunity to learn that technique, and it saves us a few difficult airway in my center, definitely.
Thank you, Dr. Prof. Ina. There's a last comment from I think from Dr. Susilo again tadi ya, ada ya. Using an MBA for difficult airway or intubation management now not contraindicated anymore if we have Sugamadex. I think.
Well, I have to comment on that. We always think with Sugamadex things are okay. You paralyze, you can reverse. But nobody ever time, I time when it's elective. Once you give Sugamadex, how long does patient wake up? Reverse completely. Have anybody time? It's not instantly. It's not instantaneous. Yes, you can. If you give 16 milligram per kilo, it's almost instantaneous, but might not be almost instantaneous. You know, they will still have that residual. What I mean is, you won't get it instantaneous. So you still need to have a plan. If patient doesn't wake up and still desaturate, declare CICO. Of course, with Sugamadex, it's an extra advantage at 16 milligram per kilo, but sometimes it's not instantaneous. Okay.
Okay. Yes, thank you. But actually, there are still many questions, and we haven't asked to the Prof. Yunita also. But don't worry for the audience, so you can still write the questions maybe in the last session, in the end of today's sessions, or we can still answer the discussion, or maybe you can, WhatsApp or still texting in the chat. So maybe Prof. Yunita or Prof. Ina still can answer, although in the simple answer. Okay, since the time is up for this session, thank you for all the participants for the questions, for the attention. Hopefully, what the professor present for today will help in our daily clinical practice. I think so many positive things and updates also. Okay, thank you. And then I will close this session with Alhamdulillahirabbil alamin. Assalamualaikum warahmatullahi wabarakatuh. Thank you for the attention.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you, Prof. Ina, Prof. Yunita, and also Dr. Jayanti for the first session of the lecture. Okay. Give applause once again for all the instruction. Very great discussion, right? Okay. For the next agenda, let's begin. For the second session, it's about pediatric neurotrauma that will be moderated by our expert also. Please welcome Dr. Muhammad Yogi Prandani, Specialist Anesthesia Therapy Intensive, as our moderator. The floor is yours.
Assalamualaikum warahmatullahi wabarakatuh. Good morning, everyone joining us here and online also. First of all, we are privileged to have our senior lecturer and our professors today, Dr. Pandi, Dr. Yusmin, Prof. Yunita, Prof. Ina, also Dr. Jayanti. So welcome to the second half of the Visiting Professor Program 2025. Today's session is titled Update in Perioperative Airway and Neurotrauma Management in Pediatric Emergency Surgery, with a special focus on the second half is on neuroanesthesia and pediatric populations. We have privilege to host our two esteemed speakers today. The first one is Prof. Girija Prasadrath joining us via Zoom, MD, DM, FICA, FAMS. Prof. Rath is renowned neuroanesthesiologist from All India Institute of Medical Science. And today Prof. Rath will present the lecture of Pediatric Anesthesia in Neurotrauma. And our second speaker will be Dr. Sudadi, Specialist Anesthesi Therapy Intensive, Subspecialist Neuroanestesi Konsultan, Subspecialist Neuro Anestesi Regional Konsultan. And today, Dr. Sudadi will give us a lecture about brain resuscitation in pediatric neurotrauma. As you know, trauma is still the leading causes of hospital admission under 16 years of age, with traumatic brain injury being a significant contributor to poor outcomes in these populations. So our role, the anesthesiologist's role in traumatic brain injury patients is spanning from emergency stabilization, surgery, intensive care, and recovery. So clear understanding of early evidence-based and multidisciplinary management is essential to improving clinical outcomes. So without further ado, let's welcome our first lecturer, Prof. Rath from All India Medical Institute. Prof. Rath, can you give us can you hear us from this room?
Yeah. Can you hear me? Good morning.
Good morning, Prof. Rath. Yes, we can hear you clearly. So the time is yours. Please give us the lecture, Prof. Rath.
Yeah, in between I was disconnected, I'm sorry. So there is some connectivity issues here, but then it is fine probably. Can the technical team can somebody help me? Because I opened two sites probably. I need to sign out from one.
Okay, Prof. We will proceed the slides for you. Full size, terus nanti ikut aba-abanya beliau buat next.
Let me sign out, then I will join again because it is causing a bit problem right now. Please bear with me.
Okay, Prof.
So I'm sharing my screen. So can you see my screen?
Yes, we can see your screen clearly, Prof. Rath. Thank you.
Slide is not moving.
Okay, Prof. Rath, we can see the slide moving right now.
This is the audio. So can you hear me right now?
Okay, we can hear you clearly, Prof. Rath.
Okay, very good morning to all of you and greetings from AIMS New Delhi in India, where I'm working at present. First of all, I must thank the organizers, particularly Professor Sudati, for this invitation to join as a visiting professor. Of course, it was not possible this time to meet you all in person. I heard Dr. Unita, Dr. Ina speaking. We'll meet some other time to all of you. And I must thank your department for this invitation once again. Just to start with my presentation, it is on pediatric anesthesia in neurotrauma. So this is the hospital where I'm working at present. Briefly about it, a couple of Indonesian colleagues have come to our department, Dr. Riyad and Priyamboda. I do remember both of them. So they did fellowship from our department at AIMS Delhi. And this is one of the tertiary care institute in India, and in fact, most sought after hospital in India, with a total bed strength of more than 3,500. And every day, near about 12,000 patients, they come to our outpatients department along with their relatives, and that includes our staffs as well. So around 50,000 people, they visit our campus every day. So it is a town inside the town. And I work for this beautiful red building, which is known as Neurosciences Center. And there is another center known as Jayaprakash Narayan Apex Trauma Center. Initially, both of them, they used to be combinedly doing the work, but these are all two departments. Our department is extended to that place as well. So near about 5,000 neurosurgical cases we operate every year, and that includes around 1,500 trauma cases, and 30% of those trauma patients, as well as all overall neurosurgical cases, include pediatric patients. So these are my disclosures. Now I'll start with the overall global burden of traumatic brain injury. It includes both adults and pediatric patients. If you see the global incidence, it is around 200 per 1 lakh population per year. In Europe, it is around 235. It is near or less same all over the world. In USA, it is 2.7 million people who sustain TBI each year, and it is a leading cause of death. 2.2 million people in USA are treated in the emergency department with 50,000 fatalities. And as far as India is concerned, it is no different. Around 2.5 million people sustain TBI every year, and 1 million of them, they succumb to death, and majority of them, they are young adults. And RTI remains the common cause of this TBI, followed by fall from heights. As far as pediatric TBI is concerned, the global incidence, it ranges from 47 to 280 per 1 lakh children. In USA alone, if you see the last decade data, 8 lakh children less than 17 years old were treated in USA. And that increased the economic burden to more than 40 billion each year in United States and 1 billion in pediatric hospital care alone. In India, children less than 15 years constitute 35% of total population, and they contribute to almost 30% of all the head injury cases. So the death rate is higher in this group of children. Particularly, it is more in children less than 4 years than those with 5 to 14 years of age. Both incidence and fatality rates are higher in boys than girls. And there is also disparity in care in this side of the world, the lower middle income category countries, with higher mortality, with fewer resources for obvious reasons. So this is a study, clinical epidemiological study from our center, and we analyzed data of around 15,000 odd patients who were suspected having head injury, and 4,800 of them were children less than 16 years old. And these patients admitted, around 1,000 odd patients were admitted, and 65% of them were boys, and with an age average of around 6.6 years. But fortunately, most of them, they were mild TBI, and the percentage of severe TBI was less than 10%. Now, what is the mechanism of injury in pediatric patients? Mainly, it is from fall from a height, and that is the most common mechanism, particularly in younger children. In older children and adolescents, it is falls followed by unintentional blunt trauma, motor vehicle accidents, assaults, etc. But one must not forget abusive head trauma, which is quite underreported, and it is common in children aged less than 2 to 4 years. So approximately 30 out of 1 lakh infants with less than 1 year are hospitalized with abusive head trauma. Now, why children are susceptible to neurotrauma? So just to tell my audience that neurotrauma includes both traumatic brain injury and spine injury. And in most of the cases of spine injury, TBI is involved. And as such, in pediatric patients, the spinal cord injury is quite rare as compared to TBI itself. So I will restrict my talk to TBI mostly. So regarding the susceptibility to neurotrauma, it is because the large head to torso ratio for adults, the autoregulatory curve, it ranges between 50 to 150, and in neonate, it is shifted to left. So you can see it is quite narrow in between 20 to 60 millimeter of mercury. So in either end, the blood pressure is pressure patient. So if the blood pressure is less, there is possibilities of hypoperfusion, and if the blood pressure is more, there is possibility of hyperperfusion. Now, to classify pediatric TBI, it is, as I mentioned in the initial slides, based on our study, it is mostly mild TBI. Fortunately, it is mild TBI. Moderate occurs in 13% of cases and severe in less than 2% of cases. As far as the pathology is concerned, it may be classified as intraaxial injuries like diffuse axonal injury, cortical contusion, intracerebral hematomas, extraaxial injuries like epidural hematoma, subdural hematoma, subarachnoid hemorrhage, intraventricular hemorrhage, and there are vascular injuries as well. Now, this is the pattern of CT scan finding you will find whenever you get do a CT scan in these pediatric patients. It may be an EDH, it may be an acute SDH, it may be a dotted contusion with diffuse axonal injury where the brain looks like a normal one other than this dotted contusion, or it may be contusion in the frontal lobes as you can see here, or it may be subarachnoid hemorrhage. Here you can see blood in the cisterns, and otherwise it may be hematoma in the intraventricular hemorrhage. So what is the pathophysiology behind it? Whenever there is a direct impact with the head, that causes the primary injury, which may be focal, like contusion, EDH, SDS, intracranial hemorrhage, or it may be global, like diffuse axonal injury. Primary head injury is usually preventable, but it is not treatable. So what follows after that is secondary injuries, and it is complicated with so many factors. So in the management of traumatic brain injury, whether it is pediatric or adult, whether it is ICU care or intraoperative care or pre-hospital care, everything revolves around hyperthermia, intracranial factors like hypohypercapnia, cerebral edema, intracranial hemorrhage, vasospasm, convulsion, fever, infection, many things that may follow. So the target is to prevent and treat these secondary injuries. So in the initial management, the primary survey has to be done and assess and stabilize the children with ABCs, airway, breathing, circulation. Then the cervical spine will have to be examined, pupillary size and reactivity to be assessed, and GCS score follows. Then the secondary thing comes, but one should remember then when we should do CT scan. So there is Pecan score to CT scan. So there is Pecan score to assess whether, because most of the children, they will be having mild TBI. So the decision to do a CT in the emergency department will depend on this Pecan score. This is Pediatric Emergency Care Applied Research Network. So this is known as Pecan rule. So if the child is less than 2 years of age with GCS 14 or other signs of altered mental status, palpable skull fracture, then CT is recommended. If that is not there, then look for occipital or parietal temporal scalp hematoma, or history of loss of consciousness for more than 5 seconds, or severe mechanism of injury. If these are there, then observe for some period of time, and it would be based on the physician's experience and multiple other things. And based on that, there should be a decision whether to go ahead with CT or not. If that is not there, then CT is not recommended. For children more than 2 years old, again with DCS around 14, with other signs of altered mental status and signs of basilar skull fracture, CT scan is recommended. But if that is not there, then look for loss of consciousness, history of vomiting, history of mechanism of injury, severe headache. So all these things are there, then they observe the patient and accordingly decide whether to go ahead with doing a CT scan or not. So if this history is not there, CT is not recommended. So when a child will have to be referred to a neurosurgeon, if the child is having persisting coma after the initial resuscitation, unexplained confusion lasting for more than 4 hours, deteriorating conscious level, especially the motor response changes, focal neurological signs, seizures without full recovery, it goes on continuously, definite or suspected penetrating injury, CSF leak. If all these things are there, there is a possibility of neurosurgical intervention. So in those cases, one should refer the patient to the neurosurgeon. So what are the indications for the neurosurgeon other than the things that is being decided? If in the CT scan, if there is an epidural hematoma of more than 30 cubic centimeter with mass effect, depressed skull fracture with dural involvement, decompressive craniectomy, if the patient is monitored with ICP lasting for more than 5 minutes or even more time, with around more than 25 millimeter of mercury. So in those cases, decompressive craniectomy is planned. And so that as early as you do all these things, there is possibility of you get a better outcome in the children. Now, what are the intraoperative or for that matter, intensive care goals? First thing is optimize cerebral perfusion and oxygenation and avoid secondary insults, which we have already discussed. Avoid and manage seizures. Again, this is also a secondary insult with anti-epileptic medications, phenytoin, levetiracetam, valproate, whatever is feasible. Avoid increase in ICP and treat intracranial hypertension. That you can do with simple maneuvers with 30-degree head up tilt and administering hyperosmolar solutions. Then adequate analgesia, amnesia, sedation, neuromuscular blockade, depending on those things that has to be given. And if indicated, early decompression should be done. Now, what about airway and intubation? When a child comes with severe traumatic brain injury, most of these children will come intubated in the emergency department. Sometimes the EDS, children with EDS, they will come non-intubated, breathing spontaneously. And when the surgery is planned, they will be intubated, surgery is done, and on the table itself, these children can be extubated. Otherwise, tracheal intubation is indicated in all severe TBI cases. Whenever it is less than 8-9, you need to intubate. GCS less than 8-9. And always use a copped endotracheal tube if it is available, because just to prevent aspiration, because the patient is in coma. Now, what are the complicated airway management? Already Dr. Ina has mentioned so many things. Just to aid in neurosurgical perspective on complicated airway management. When you say that in a neurosurgical child, the airway is treated, there is urgency of hypoxia, uncertainty of C-spine status. We don't know, sometimes the C-spine fracture is there. Uncertainty, it is mobile. Uncertainty of oropharynx, it may contain some food material, blood, and maybe it is injured. That may complicate the thing. You cannot visualize the things. Uncertain volume status, the child must have taken food. And intracranial hypertension, already intracranial hypertension is there, and you need to intubate the child as soon as possible. So in those cases, there is a possibility that you go for rapid sequence induction and record pressure. And mostly, like she has mentioned, Dr. Ina has mentioned, it is always a video laryngoscope. It helps in the emergency department with manual inline stabilization, because you don't know about the C-spine status. And succinylcholine, that's what also she has mentioned. You should not go for a non-depolarizing muscle relaxant, even for that matter, rocuronium in a higher dose. Just go ahead with succinylcholine. The amount of raised ICP the succinylcholine will cause, it will less than if you give a non-depolarizing muscle relaxant and wait for more period of time, not able to ventilate a child. So anesthesia technique-wise, IV anesthetic agents, as we know, these are all cerebral vasoconstrictors. So they decrease cerebral blood flow, blood volume, cerebral metabolic rate of oxygen, and hence reduce ICP, thereby increasing CPP, because ICP, mean arterial pressure minus ICP is the CPP. As far as ketamine is concerned, previously it was contraindicated, but nowadays it is considered as safe. Whenever there is a hypotensive episode in a child, it is go ahead with giving ketamine. It has certain neuroprotective effect as per various literature right now. And particularly when the child is having hypotension, and it is considered safe with controlled ventilation. As far the opioids are concerned, you can give fentanyl, remifentanil, because even for that matter, benzodiazepines, they have minimal effect on the cerebral hemodynamics with controlled ventilation. Inhalation anesthetic agents, they are all cerebral vasodilators, be it isoflurane, desflurane, or sevoflurane. They reduce CMRO2, but may cause cerebral vasodilatation, thereby increasing ICP. But at a MAC of less than 1, particularly in sevoflurane, it has minimal effect on this cerebral vasodilatation. So sevoflurane is preferred, that is the reason in these children. But one must avoid nitrous oxide because it increases the metabolism, also causes cerebral vasodilatation, so increases ICP. Sorry, I'm not able to move this slide. Yeah. So then comes the ventilation strategy. The goal is to provide adequate oxygenation and avoid PaO2 less than 60 millimeter of mercury. So hypoxia, as I mentioned in the initial slides, that it is a big risk factor for adverse outcome. So it has to be avoided and maintain normocapnia because as per the recent guideline, pediatric TBI guideline, one must avoid prophylactic severe hyperventilation to less than 30 millimeter of mercury, and there is a level 3 evidence in support of it. Also, there is a level 3 evidence in support of avoidance of hyperventilation in first 48 hours because hyperventilation causes vasoconstriction, thereby decreasing ICP. At the same time, there is possibility of um, cerebral ischemia, thereby it increases morbidity and mortality, and it happens particularly in the initial phase of TBI. So when hyperventilation can be utilized in TBI, only for refractory intracranial hypertension along with advanced neuromonitoring like jugular venous oximetry, brain tissue oxygen tension monitoring. So all these things can be done. Now, if you are using jugular venous oximetry in a child, so how to assess jugular venous oximetry so that you can institute therapy? The normal value is 50 to 70%, and it is a broad range. And less than 50, it definitely increases the morbidity and mortality. So if that is there, then look for hypoxia, that saturation, whether it is less than 90%. In that case, correct hypoxia. If that is not there, then look for hypocapnia. If the PaCO2 is less than 25 millimeter of mercury, then raise the PaCO2. If that is not there, then look for anemia. If the hematocrit is less than 30%, then transfuse blood. If that is not there, none of these things are there, but still the jugular venous oximetry value is less than 50%, then look for all other measures like we are using giving mannitol, furosemide, thiopentol, whatever the measures we are doing, we'll have to do that. Now, hemodynamic management. We know a single episode of hypertension can adversely affect the outcome. So it is important to maintain the blood pressure above the 5th percentile of the child's age. In adult patient, it should be the systolic blood pressure should be more than 90 millimeter of mercury. The CPP should be in between 40 to 50 millimeter of mercury in small children. For adolescents, it should be around 50 to 60 millimeter of mercury. There is a terminology called decompressive hypotension, and it is usually encountered at the time of dural opening. Once the decompression is planned in the operating room, you will find at the time of dural opening, there will be hypotension and it will be sustained. And in adult patients, it is predicted by low GCS, FS systems, and bilateral dilated pupil. So you will have to be careful in those cases by giving fluids and vasopressors, whatever is necessary. There is always a risk of intraoperative hypotension in the children because and it can be identified from multiple lesions in CT, STS, and prolonged anesthesia, and it should be promptly treated. In any case, hypotension should be avoided. Now, what about fluid management? The target is to maintain euvolemia, which should be guided by the blood pressure measurements and urinary output, and sometimes, if it is possible, to put a central line. Hypovolemia is usually masked by a stable blood pressure. Sometimes you will find a patient is coming, a child may be coming with a stable blood pressure. Once you induce the children, the blood pressure will crash. So although it looks like a stable blood pressure, it is not the normal value. It is secondary to the sympathetic hyperactivity or reflex response to increased ICP. So you'll have to be careful while inducing the children in that condition. Isotonic crystalloids are usually preferred. Ringal lactate is hypotonic, so most of the time these are avoided. But for large volume resuscitation, normal saline nowadays commonly used because the role of colloids is controversial because they cause coagulopathy. So if you are giving large volume of normal saline, there is a possibility that metabolic hyperchloremic acidosis may occur. Of course, that may subside over a period of time. If you are giving at a dose of around 60 ml per kg, more than 60 ml per kg body weight, there is a possibility of this metabolic hyperchloremic acidosis that may occur. Now, vasopressor, if the hypotension is there, if you are not able to manage it with fluids, then you should go for vasopressor. So, which is the best vasopressor? There is no evidence in support of that this one is perfect. The studies have compared specific drugs, and there is one study by Johnson and colleagues. It's an old study. They compared noradrenaline with dopamine. They have equal effect on flow oxygenation and metabolism. Noradrenaline was found to be more consistent as compared to dopamine, because dopamine may cause higher ICP, rise in higher ICP, because in various concentration, it will be having various effects. As far as phenylephrine is concerned, it causes maximum increase in mean arterial pressure and CPP without changing ICP. So it can be preferred in the intraoperative period. As far as glycemic control is concerned, the target is to maintain euglycemia, but sometimes hyperglycemia may be associated. That may lead to worse outcome in these TBI patients. And as per the adult studies, there are various risk factors for new onset hyperglycemia, which is almost 15% in this patients, and that has been observed in the intraoperative period. So in those cases, insulin may be given if it at all it is required in graded manner. The risk factors include severe TBI, SDS, and preoperative hyperglycemia, and frequently monitor the intraoperative sugar values, and a value more than 200 milligram percent or more than even 180 milligram percent should be avoided. Whether to go ahead with tight glucose control with intensive insulin therapy, that is again controversial, because that causes many episodes of hypoglycemia, and as you know, hypoglycemia is even more dangerous than hyperglycemia, so it has to be avoided. Now, as far as ICP and CPP monitoring is concerned, when the patient is posted in the for surgery, before that the patient may be monitored in the ICU. So the target should be less than 20 millimeter of mercury, and PbTO2 may be kept more than 10 millimeter of mercury if it is available. These are all recommendations as per TBI, pediatric TBI guidelines, and the CPP should be kept, as I mentioned earlier, 40 to 50 millimeter. So the indications include severe TBI with abnormal CT finding, and children with high risk of moderate TBI, like children having systemic hypertension, abnormal pupillary responses. So in those cases, it is an option if ICP monitoring is available, then somebody can monitor inside the ICU. Otherwise, the conventional method is routinely used. And if the ICP is more than 20, intervention is required, as we have discussed already. And the CPP goal also we have discussed. So what is the tiered therapy for children? The first line is, as I mentioned, head elevation, sedation, and hyperosmolar therapy. And many studies suggest that 3% hypotonic saline is better than mannitol. That is why it has been recommended in this group of in children as compared to adults. Adults, people are still using mannitol, although newer studies recommend otherwise, but there is no consensus whether to go ahead with 3% hypotonic saline or mannitol. In our center, we are still using mannitol. The second line management is CSF drainage and neuromuscular blockade, and the third line management is decompressive craniectomy and even barbiturate coma. So what about hyperosmolar therapy in pediatric patients? As far as ICP control is concerned, bolus dose of hypotonic 3% hypotonic saline is recommended in children with intracranial hypertension, and the dose should be in between 2 to 5 ml per kg over a period of 10 to 20 minutes. And as far as the continuous infusion of 3% hypotonic saline is concerned, in cases of intracranial hypertension, at a dose of 0.1 to 1 ml per kg body weight per hour should be used in sliding scale. Targeting the ICP should be less than 20. As far as the other hypotonic saline are concerned, 23.4% hypotonic saline can be used for refractory ICP. There are certain recommendations in favor of that, but those are level 3 recommendations, and the suggested dose is 0.5 ml per kg with a maximum of 30 ml. Now, temperature control, the target is to maintain normothermia because prophylactic moderate hypothermia is not recommended just to improve the overall outcome in this pediatric TBI patients. But for ICP control, the temperature control means moderate hypothermia may be helpful at around 32 to 33 degrees centigrade. So if we are using hypothermia, the rewarming rate should be slow. It should be 0.5 to 1 degree centigrade every 12 to 24 hours to avoid those complications. And phenytoin should be given very carefully because there is possibility of bradycardia and even cardiac arrest. Now, barbiturate coma, sometimes it is required. In those cases, it should be utilized in the postoperative period if still with decompressive craniotomy, even if it is not helping the child and the ICP monitoring shows higher values, in those cases, somebody can go for as a third tier therapy, can go for barbiturate coma, maintaining the blood pressure with vasopressors. So just to summarize my talk, TBI is the leading cause of death in children more than 1 year of age. 50% of children with spinal cord injury have an associated TBI. Diffuse axonal injury, cerebral edema, these are all most common findings on CT scan, with particularly with children with severe, moderate to severe TBI. Children with severe TBI need tracheal intubation for airway protection and also management of ICP in intracranial hypertension. Cervical spine must be immobilized in all cases with suspected injury. GA in these cases, general anesthesia consists of either IV or volatile anesthetic agents. Both you can use. Of course, when you are using volatile anesthetic agents, it should be less than 1 mg, along with opioid boluses and muscle relaxants. Hypotension and hypoxia should be treated as soon as possible, restoring hypovolemia, followed by vasopressors. Hyperventilation should be avoided unless there is signs of brain herniation. So is a temporizing measure that can be done. Intracranial hypertension may need treatment with hyperosmolar therapy. Secondary brain injuries should be prevented if at all it occurs. If at all it is observed, it should be aggressively treated. And just to further summarize, the take-home message is the major goal is to prevent secondary injuries, be it in the preoperative period, intraoperative period, or postoperative in the ICU management. The therapeutic measures, whatever I have discussed, they are all extrapolated from the guidelines, which are based on the ICU management and rest of the things. And these guidelines must be instituted because there is not much data available with regard to intraoperative course in this pediatric TBI, for that matter, even adult TBI patients. But one must remember that all these recommended guidelines may not improve the outcome. And that is why we need to stay tuned with all the upcoming guidelines and accordingly manage our patient. Thank you very much.
Thank you very much, Prof. Rath. So for the next lecture will be given by Dr. Sudadi, Specialist Anesthesi Therapy Intensive, Subspecialist Neuroanestesi Consultant, Subspecialist Anesthesi Regional Consultant. Dr. Sudadi will give us lecture about brain resuscitation in pediatric neurotrauma. A little bit about Dr. Sudadi. So Dr. Sudadi right now is still active as Vice Dean in Fakultas Kedokteran Universitas Gadjah Mada, and also senior staff and lecturer at Sarjito Hospital and consultant anesthesiologist in Sarjito Hospital. So without further ado, time is yours. Dr. Sudadi, everyone. Please give round of applause.
Assalamualaikum warahmatullahi wabarakatuh. Honorable my friend Prof. Rath from All Indian Institute, thank you for joining our program Visiting Professor 2025. Actually, this day Prof. Rath come to Jogja, but because he is very busy and maybe reschedule next month. Yeah. Thank you, Prof. Ina, coming to Jogja. I hope you're happy in Jogja. Yeah. Thank you, Prof. Yunita, Dr. Pandit, and all participants. Yeah. Let me speak in Bahasa Indonesia because maybe it's easy for me to deliver my lecture. Yeah. Bapak Ibu yang saya hormati, mungkin materi saya tidak terlalu jauh dengan apa yang telah disampaikan oleh Prof. Rat, ya. Karena memang untuk mempersiapkan pasien bisa dilakukan anestesi dengan baik, mungkin prosedurnya tidak terlalu berbeda. Dan pada saat ini saya akan menyampaikan mengenai brain resuscitation pada pasien pediatrik yang mengalami traumatic brain injury. Dan tentu bahwa brain resuscitation ini untuk mendapatkan outcome supaya pasien baik dan kemudian dilakukan teknik anestesi. Ya. Tentu bahwa brain resuscitation ini akan terjadi begitu impact pertama atau primary injury sampai pasien betul-betul sembuh. Ya. Jadi di sini penting bagi kita untuk mengetahui patofisiologi dari pediatric traumatic brain injury, kemudian tentu kita harus bisa membedakan parameter-parameter yang ada pada pediatrik dengan dewasa, karena pediatrik sebetulnya bukan dewasa kecil, tetapi mempunyai parameter-parameter yang berbeda. Kemudian kita akan mengaplikasikan guideline untuk manajemen. Tadi sebetulnya Prof. Rat sudah banyak menyampaikan mengenai teknik-teknik untuk manajemen ini. Saya akan mensarikan dari beberapa guideline, karena ternyata perkembangan guideline pada pediatrik itu begitu cepat, ya, update-nya. Ya. Kalau dari Brain Trauma Foundation, dia mengeluarkan mungkin setiap 10 tahun. Ya. Tahun 2007, kemudian 2016, 2017. Ya. Nah, tahun 2019 sudah ada update dari pediatrik. Kemudian tahun 2023 juga sudah ada update lagi. Nah, ini saya akan menyampaikan beberapa hal, moga-moga nanti bisa bermanfaat bagi kita semua. Ya. Bapak Ibu sekalian, kalau tadi disampaikan oleh Prof. Rat mengenai epidemiologi, ya, ternyata bahwa 475.000 traumatic brain injury setiap tahunnya ini terjadi pada pasien-pasien yang kurang dari 14 tahun. Ini di US. Nah, perlu kita ketahui di sini ada beberapa hal yang penting, ya. Walaupun puncaknya di anak-anak umur 5 sampai 12 tahun, tetapi preschool 1 sampai 4 tahun dan 13 sampai 6 tahun ini mempunyai kejadian yang mirip, ya, sama-sama banyaknya. Nah, ini perlu kita perhatikan bahwa kejadian ini bisa saja terjadi dengan karena jatuh dan sebagainya. Nah, mungkin anak-anak 13 sampai 16 tahun baru belajar naik sepeda motor, naik sepeda, sehingga banyak kecelakaan di sana. Dan ini penting bagi kita juga, ya, bahwa ternyata laki-laki lebih banyak daripada perempuan. Mungkin anak laki-laki lebih ngelidik, gitu ya, sehingga banyak jatuh dan sebagainya. Oke, ya. Kemudian mengenai patofisiologi, walaupun tadi sudah disampaikan, tetapi penting bagi kita untuk mengetahui primary injury. Tadi sampaikan bahwa primary injury ini begitu terjadi impact, jatuh, impact pertama bisa terjadi kontusio, bisa terjadi laserasi, bisa terjadi perdarahan dari EDH, SDH sampai ICH, ya. Kemudian yang terakhir aksional diffuse injury. Ini yang mungkin secara radiologis tidak begitu nampak, walaupun dengan scanning, ya. Tetapi kadang-kadang klinis pasien bisa tidak bangun, ya. Kemudian secondary injury, ini merupakan kaskade dari biochemical. Jadi kalau sejawat sekalian pernah baca mengenai kaskade iskemik, ya, di sini dari mulai kekurangan oksigen dari supply and demand, nanti akan muncul bermacam-macam kejadian. Ada inflamasi, ada edem dari cerebral, hipoperfusi, kemudian excitotoxicity. Yang di sini adalah merupakan kelanjutan dari primernya. Jadi kalau primer, kemudian terjadi hipoksia, hipoksianya bisa terjadi karena suplai dari oksigen yang kurang ataupun karena pressure yang turun sehingga delivery oksigen ke target di otak yang berkurang. Kemudian goal daripada kita untuk tata laksana ini tentunya kita bisa memaintain ataupun menjaga perfusi ini dengan baik. Ya. Kemudian kontrol dari tekanan intrakranial, mencegah kejang, dan juga kelainan metabolik. Ini goal utama pada saat kita melakukan tata laksana pada pasien pediatrik traumatic brain injury. Jadi walaupun mungkin bayi anak-anak itu sudah masih fontanelanya belum nutup, ya, tetapi karena edemnya mungkin berat, tetap akan terjadi kenaikan tekanan intrakranial. Ini yang harus kita treatment bersama. Ya. Nah, kalau dari sisi primary injury, direct mechanical damage, begitu terjadi benturan bisa terjadi kontusio dan sebagainya, ini tadi sudah kemudian sel membran disruption yang ini akan berakibat adanya axonal injury, ya, jadi membran sel yang rusak, kemudian ion dysregulation ini keseimbangan elektrolit yang akhirnya terjadi kaskade yang memperjelek kondisi, kemudian NMDA receptor activation ini yang menyebabkan excitotoxic mechanism. Ya, sehingga di sini mungkin sebetulnya kalau kita lihat dari bagian ini, ya, ini semua jalur ini kalau bisa dipotong, ini sebetulnya merupakan brain protection dan brain resuscitation sebetulnya. Jadi misalnya dari adanya secondary brain injury, kemudian adanya rilis glutamat, bagaimana kita bisa memotong di sana, kemudian ada radikal bebas, bagaimana kita bisa memotong di situ. Nah, ini sebetulnya rangkaian-rangkaian yang ada di sana sebagai brain protection. Oke, nah kemudian kalau lebih lanjut lagi, ya untuk brain protection, untuk secondary, kita akan mencegah supaya blood-brain barrier ini tetap intak. Ya. Walaupun pada saat terjadi trauma pasti ada yang rusak, tetapi bagaimana kita menjaga meminimalkan kerusakan yang ada. Tentunya banyak hal yang bisa kita kerjakan. Kemudian neuroinflamasi, nah ini adanya badai sitokin, bisa terjadi hal yang tidak kita inginkan. Kemudian tadi glutamat mediated neuronal damage menjadi excitotoxicity, dan yang terakhir oksidasi stres. Ya. Sebetulnya secondary injury ini bisa kita cegah dengan baik tindakan kita oksigenasi yang baik, kemudian bagaimana kita melakukan terapi cairan dan juga obat-obat tertentu. Ya, sehingga 4 kejadian ini bisa kita minimalkan. Oke, Bapak Ibu sekalian, tadi sebelum kita melakukan suatu tindakan, tentu kita harus mendiagnosis. Ya. Asesmen klinis untuk diagnosis, tadi sudah disampaikan oleh Prof. Raj, bagaimana kita menilai kesadaran dari pasien dengan GJS tentunya, kalau pediatrik mungkin dengan modifikasi, ya. Kemudian bagaimana respon dari pupil, kemudian bagaimana kelainan neurologis yang ada, motoris, kemudian refleks dari brainstem, ya. Dan yang terakhir adalah non-incidental trauma screening. Nah, di sini dengan indeks dari suspicion index, ya. Oke, nah untuk diagnosis tadi sudah mengenai scanning tanpa kontras, tadi sudah disampaikan bagaimana kalau umurnya kurang dari 2 tahun dengan segala macam akibatnya. Ya. Kemudian bagaimana pengulangan kalau misalnya harus dilakukan, apakah direkomendasikan atau tidak. Oke, nah kembali lagi treatmentnya. Kalau sudah dilakukan diagnosis, treatmentnya adalah kita mencegah supaya tidak terjadi iskemik, tidak terjadi hipoksia, dan tentunya menurunkan atau oksigen demandnya yang diturunkan sebetulnya di sini. Oke, ya. Nah, pertama tadi sebetulnya secara umum mengenai airway management sudah dibahas baik oleh Prof. Yunita maupun Prof. Ina, ya. Bagaimana kapan kita memerlukan intubasi, tentu kalau GCS-nya kurang dari 8 karena sudah tidak bisa mempertahankan airway. Ya. Nah, penting bagi kita bagaimana cara kita melakukan, ya. Apakah kita masih memerlukan ETT yang dengan cuff atau tidak, tadi sebetulnya sudah banyak disinggung, ya. Apakah kita menggunakan RSI dan obat-obat apa saja yang dipakai, ini sudah dibicarakan. Ya. Nah, mengenai strategi ventilasi, ya. Di sini kita menjaga supaya tidak terjadi hiperventilasi. Kenapa? Hiperventilasi dengan PaCO2 kurang dari 30 mmHg akan menyebabkan vasokonstriksi, padahal otaknya sendiri sudah iskemik. Ya. Kalau terjadi vasokonstriksi di otak yang sudah iskemik akan makin iskemik. Jadi hiperventilasi hanya boleh dilakukan kalau ada tanda-tanda casing sign. Nah ini yang menjadi perhatian kita. Ya. Target parameter sebetulnya kalau PCO2 adalah normoventilasi 35-40 ya, dengan PaO2 tadi sudah disampaikan juga 60 mmHg dengan saturasi lebih dari 92. Kita bisa melakukan monitoring dengan end-tidal CO2, kemudian blood gas analysis maupun dengan pulse oximetry. Ya. Nah, penting juga untuk hiperventilasi ini, ya, kalau ada tanda-tanda akan herniasi, itu baru boleh dilakukan hiperventilasi dengan PCO2 30-35 dan maksimum hanya 20 menit. Ya, jadi tidak boleh seharian dengan hiperventilasi. Oke, kemudian mengenai hemodinamik. Ya. Hemodinamik kalau pada dewasa mungkin dengan patokan umur 15 sampai 49, kemudian 50 sampai 65 dan sebagainya, mungkin pada orang dewasa di atas 110 mungkin aman. Ya. Tetapi pada pediatrik mempunyai karakteristik tekanan darah yang berbeda. Umur 0 sampai 1 bulan ini systolic blood pressure-nya 60 minimalnya. Pada umur 1 sampai 12 bulan 70 mmHg. Dan kalau lebih dari 10 tahun baru 90 mmHg. Jadi tidak semua kita kebiahuyah dengan lebih dari 100 mmHg seperti pada dewasa. Ya. Nah, kemudian mengenai cairan, ya, gunakan cairan isotonik. Ya, di sini pindah dengan normal salin maupun LR dan tadi dipertanyakan kalau kita menggunakan koloid. Ya. Tetapi nanti ada treatment bagaimana kita bisa memberikan cairan dengan osmolaritas yang lebih tinggi. Ya. Nah, penting bagi kita untuk memonitor MAP maupun CPPP secara kontinus pada trauma yang berat. Ya. Nah, ini penting bagi kita untuk nggak bisa kembali yang tadi ya. Bisa di set kembali yang tadi Mas. Oke. Airway sudah ya, oke. Kok malah meloncat ya? Kalau maju kurang yang tadi yang mengenai hemodinamik bisa Mas. Lagi. Oke, ya. Nah, penting bagi kita bahwa satu episode hipotensi ini akan menyebabkan 2 kali mortalitasnya naik tinggi. Jadi jangan bikin pasien traumatic brain injury pada pediatrik maupun pada orang dewasa. Begitu tensinya turun, tidak segera kita naikkan, pasti outcome-nya akan jelek. Nah, ini menjadi perhatian bagi kita ya. Oke, ICP monitor. Nah, ICP monitor ini penting bagi kita pada GCS kurang dari 8, ya, post resusitasi. Ini perlu dilakukan ICP monitor dengan target kurang dari 20 mm lagi. Ya. Pada dewasa, rekomendasi internasional adalah 22. Ya. Tetapi pada pediatrik tidak boleh lebih dari 20. Ya. Nah, monitor yang bisa kita berikan itu bisa dengan EVD, ya, external ventricular drainase, yang kemudian disambung dengan manometer. Apakah itu dengan elektrik ataupun dengan manometer yang manometer air, ya itu juga bisa, tidak masalah. Nah, ini bisa langsung akan ketahuan berapa tekanan di dalam ventrikelnya. Ya. Kemudian yang monitor elektrik kita bisa intraparenchyma maupun subarachnoid yang kemudian dibor ke sama saja di penempatannya di ventrikel bisa, tapi yang dengan elektronik. Ya. Tapi yang paling mudah EVD yang ada sambungkan aja dengan manometer. Ya. Nah, rekomendasinya untuk ICP strong recommendation, tetapi evidence base-nya masih very low. Ya. Nah, di sini penting bagi kita untuk ICP ini bisa termonitor dengan baik. Ya. Oke, nah kemudian mengenai CPP. Ya. CPP umur 0 sampai 5 tahun ini dipertahankan 40 sampai 50, sedangkan 6 sampai 17 tahun 50 sampai 60. Pada dewasa itu 50 sampai 70. Nah, di sini parameter yang bisa kita gunakan dengan monitor arteri lain ataupun ICP monitor, dengan kita bisa memberikan kalkulasi, ya, di mana CPP sama dengan MAP dikurangi ICP. Kalau ICP-nya sudah dapat, MAP-nya kita bisa kalkulasi, ya, itu CPP-nya bisa kita dapatkan. Nah, di sini parameter-parameter untuk CPP, ya. Dan ini high maupun low CPP ini sangat berhubungan dengan outcome. Ya, kalau CPP-nya terlalu rendah, artinya di sana perfusinya akan jelek, ya, sehingga outcome-nya menjadi kurang baik. Ya. Oke, terapi hiperosmoler tadi sudah disampaikan oleh Prof. Rat juga. First line-nya yang merupakan rekomendasi dari guideline tahun 2012 adalah dengan 3% hypertonic saline. Ya. Dan ini lebih baik dibandingkan dengan mannitol secara evidence base. Ya. Kita bisa dengan dosis 2-5 mili per kilogram berat badan bolus selama 10-20 menit, kemudian dilakukan maintenance 0,1 sampai 1 mili per kilogram berat badan per jam continuous, ya, dengan target serum natriumnya 150 sampai 160. Nah, penting di sini kita harus memonitor natrium, kemudian osmolaritas, kalium, bun, kreatinin ini pada waktu kita melakukan terapi dengan hiperosmoler yang progresif. Ya. Jadi kenaikan yang terlalu signifikan akan berakibat yang kurang baik juga. Ya. Kemudian untuk mannitol ini dosisnya 0,25 sampai 1 gram per gram 30 menit. Kemudian dengan target osmolaritas 300 sampai 320, ya, maksimum serumnya 320. Nah, ini sebetulnya tidak terlalu jauh dengan parameter pada dewasa. Ya. Nah, rekomendasinya ini strong recommendation, very low quality evidence. Jadi tetapi tetap bahwa rekomendasi untuk menurunkan tekanan intrakranial kita bisa menggunakan cairan hiperklorid tadi. Ya. Oke, nah bagaimana dengan profilaksi dari kejang? Ya. Ada dengan profilaksi dari kejang. Ya. Ada first line agent-nya itu dengan levetiracetam, ya, loading dose-nya 60 mg per kilogram berat badan. Alternatifnya adalah dengan penitoin. Biasanya di kita yang tersedia adalah penitoin, ya, loading dose 20 mg per kilogram badan per enteral, ya, maintenance-nya 5 mg per kilogram berat badan per hari. Ya. dibagi dalam 2 dosis. Ya. Nah, kita harus melakukan monitoring dari kejang ya, dengan EEG, bisa dengan continuous, ya apalagi pada pasien dengan GCS yang kurang dari 8. Nah, nah kalau sudah lebih dari 7 hari, kemudian profilaksis kejang ini tidak direkomendasikan. Jadi profilaksi untuk kejang ini diberlakukan selama 0 sampai 7 hari. Nah, rekomendasinya adalah strong recommendation. Ya, Kemudian untuk temperatur, ya, normotermia ini yang dianjurkan 36 sampai 37, dan kita harus hati-hati bahwa terapi hipotermi tidak direkomendasikan. Nah, pada dewasa direkomendasikan, tapi pada anak-anak ini tidak direkomendasikan. Nah, sehingga ada treatment kalau misalnya pasien panas lebih dari 38 derajat, berikan antipiretik, ya, ataupun dengan pendinginan pada permukaan, ya, dan juga kita harus menjaga supaya tidak terjadi hipotermi di mana suhunya kurang dari 36 derajat. Nah ini rekomendasinya adalah strong recommendation dengan moderate quality evidence, artinya bahwa evidence-nya cukup bagus. Kemudian untuk sedasi kita bisa menggunakan fentanyl sampai 1-2 mikro per kilogram berat badan per jam, continuous infus, ataupun dengan midazolam 0,05 sampai 0,1 mg per kilogram berat badan continuous, dexmedetomidine maupun propofol. Ya. Nah, penting bagi kita kalau ketamin, ya mungkin perlu kita hindari, ya. Tapi mungkin pada kondisi tekanan darah yang rendah masih memungkinkan kita menggunakan ketamin. Ya. Kemudian neuromuscular block, kalau dilakukan ventilator, ya. Propofol ini yang perlu kita perhatikan adalah kalau ada propofol infusion syndrome, ini harus kita monitor dengan baik, apakah ada acidosis, rhabdomyolysis dan sebagainya. Kemudian untuk nutrisi, nah kapan harus diberikan nutrisi, rutenya lewat mana, komposisinya seperti apa, dan monitoringnya seperti apa, nah, ini yang penting ketahui bahwa nutrisi bisa diberikan 70 jam setelah injury. Ya. Ini yellow feeding juga penting banget, ya. Rutenya sebisa mungkin adalah dengan enteral, ya, bukan parenteral. Komposisinya dengan menghindari immune modulating diet, ya. Monitoringnya mungkin dengan penimbangan berat badan dan sebagainya. Nah, CSF, drainase dari LCS. Ini penting pada kondisi terjadi peningkatan tekanan intrakranial yang terlalu tinggi. Kalau pasiennya ini sudah dipasang EVD mungkin tidak terlalu sulit karena tinggal mengalirkan, ya. Utamanya pada pasien yang dengan hidrosipalus. Ya. Tekniknya tadi, ini ternyata rekomendasinya justru dengan EVD sebetulnya. Kalau pada orang dewasa selain dengan EVD bisa dengan lumbal drainase epidural tap yang dialirkannya. Selama ini mungkin kita sudah beberapa kali mengerjakan, tetapi dengan epidural kit, ya, sebetulnya ada epidural drain yang khusus sebetulnya untuk tapping ini. Ya. Ada protokolnya tersendiri bagaimana supaya tidak terjadi infeksi dan sebagainya. Kemudian untuk barbiturat koma, nah ini kalau terjadi hipertensi intrakranial yang refraktori, kita bisa lakukan hipertensi koma barbiturat dengan dosis awal, loading dose-nya 5-10 mg per kilogram berat badan IV selama 30 menit, kemudian maintenance-nya adalah 0,5 sampai 5 mg per kilogram berat badan per jam, dan ini perlu dilakukan titrasi untuk menghindari supresi dari EEG yang berlebihan. Ya. Monitoring yang dilakukan adalah dengan EEG continuous, ya. kemudian invasive hemodynamic monitoring karena rentan pada pemberian koma barbiturat ini terjadi penurunan tekanan darah ini yang tidak kita inginkan karena akan menyebabkan outcome yang justru menjadi lebih jelek lagi. Nah, antisipasi di sini supaya tidak terjadi hipotensi, disiapkan vasopresor, ya. Kemudian juga dilihat apakah terjadi depresi dari miokardial, immunosuppression dan juga prolong recovery ini yang perlu diperhatikan. Ya. Kemudian rekomendasinya ini rekomendasinya adalah weak recommendation, artinya tidak terlalu kuat, ya. Very low quality evidence, jadi evidence-nya memang tidak terlalu kuat juga. Ya. Ini tadi bagaimana melakukan koma barbiturat sudah. Ya. Nah, sejawat sekalian, ya. Penting bagi kita pada saat kita melakukan tata laksana pada pasien pediatrik supaya outcome-nya baik, khususnya untuk traumatic brain injury, ya, early intervensi ini sangat penting. Ya. Ada keterlambatan, biasanya outcome-nya kurang begitu baik. Tadi sudah ditekankan sama Dr. Jayanti. Ya. Kemudian precision medicine, jadi mungkin kedepannya untuk precision medicine ini menjadi suatu hal yang penting. Ya. Multimodal monitoring. Nah, saat ini kadang-kadang kita monitoringnya tidak lengkap. Nah, semakin banyak kita lakukan monitoring, kemudian kita bisa melakukan action pada treatment-treatment yang kita berikan, itu akan semakin baik. Dan tentu yang terakhir, multidisiplin ini sangat penting. Ya. Anestesiologis mungkin mengetahui hal-hal yang emergensi, tetapi yang basic mungkin teman-teman dari pediatrik juga mungkin lebih expert. Ya. Saya kira itu yang bisa saya sampaikan. Terima kasih. Assalamualaikum warahmatullahi wabarakatuh.
Okay, so thank you, Dr. Sudadi, for the lecture. Now we come to discussion part. If there are any question from this room first. We'll open up to 5 questions, 2 from this room and 3 from online audiences. Yeah, okay, Dr. Finn.
Baik. Perkenalkan saya Alvina dari semester 5, mohon izin bertanya baik untuk Dr. Sudadi dan Prof. Girija. Izin dalam bahasa sorry. My question is both for Prof. Girija and Dr. Sudadi about the use of hypertonic saline 3% and mannitol for every day on our daily practice. We usually get the patient from our colleague from the neurosurgeon, and they often use mannitol as part of their therapy. But the guideline shows that it is recommended for use hypertonic saline. What should we do in this situation? Because they've already given mannitol in the first place. Can we change it, or for the next time we give the fluid, should we still use mannitol? Thank you.
So, yeah, Dr. Sudadi, should I take this question?
Okay, so Prof. Rath, the question is if the patients given hypertonic saline before, for the next administration, can we change it into hypertonic saline, or we should continue the mannitol that's been given?
Yeah, means there is no hard and fast rule that you should continue with the thing whichever you have started, but it is better to continue with that. But then the second part of question probably I understood is neurosurgeons and neurosurgery colleagues, they are insisting on giving mannitol as a choice. Is that correct?
Yes, Prof.
Yes. So not a problem, means whatever you are giving, ultimately it is how you are giving the medication is important rather than what medication you are giving. So if the dose range is all right, if you are monitoring properly with all other parameters, then it is all fine. The people, those who are practicing hyperosmolar solution since a long, they prefer giving mannitol. That is the reason if you go through the adult TBI guidelines, they are still using mannitol. The reason being there is not much evidence available as far as hypotonic saline is concerned. But in this scenario, what you can divide is if if a patient is coming with low BP, and if you don't want to transfuse a lot of crystalloid, so in those conditions, you can prefer hypotonic saline rather than mannitol, because that will cause diuresis and further reduce the blood pressure. So this is what broadly you can remember. But in children, many of the studies, they suggested that hypotonic saline can be used. It is a guideline, but definitely it is not the standard of care. Standard of care means there is level 1 evidence is there. It is level 2 evidence that is there. So that is what. So it is all your choice.
Dr. Sudadi, ada yang ingin ditambahkan? Silakan, Dok.
Saya kira sama aja dengan yang disampaikan Prof. Rat ya teman. Bagi kita penting bahwa secara evidence base bahwa salin hipertonik itu lebih baik daripada mannitol. Itu aja. Nah kalau kita menggunakan mannitol toh penghentiannya tidak boleh tiba-tiba, berarti harus ada tapering. Nah ini yang harus kita perhatikan. Saya kira itu.
Okay, thank you, Dr. Sudadi. Thank you, Prof. Rat. Next question from this room. Ya, silakan Dr. Pandit.
Untuk Dr. Sudadi, apakah pasien post craniotomy untuk pediatrik itu rekomendasinya as fast as possible extubate or on ventilator at least 1 or 3 days in ventilator in ICU?
Saya kira terima kasih Dok, ini pertanyaan yang sangat bagus ya. Jadi kapan kita boleh melakukan ekstubasi, apakah boleh fast track ataupun harus delay di ruangan, tentunya tergantung dari sejauh mana manipulasi yang dilakukan oleh surgeon. Ya, apakah ini misalnya perdarahan, seberapa banyak perdarahan, seberapa lama manipulasinya, kemudian kalau pasien tumor, misalnya tumor, ini seberapa besar tumornya dan tadi seberapa besar manipulasi perdarahannya dan sebagainya. Ini kalau misalnya waktu tindakannya cukup lama, tentunya kita tidak boleh buru-buru untuk ekstubasi. Saya kira begitu.
Especially for trauma.
Untuk khususnya untuk trauma, saya kira tidak boleh terlalu cepat diekstubasi, karena trauma ini kan tidak single perdarahan di situ terus kemudian ada edem. Trauma selalu akan odemnya luas, ya, sehingga recovery-nya tentu memerlukan suatu waktu, ya, tergantung seberapa luas traumanya. Ini penting bagi kita untuk bisa menentukan apakah early ekstubasi. Nah, kemudian juga modal dasarnya, GCS awalnya seberapa. Kalau misalnya datang dengan GCS di bawah 8, tentunya kita tidak boleh buru-buru untuk ekstubasi. Tetapi kalau misalnya tidak terlalu, misalnya GCS di traumatik yang ringan, GCS-nya masih sekitar 13-15, kemudian perdarahannya superficial, saya kira bisa dilakukan ekstubasi segera.
Patroan binningnya, kalau patroan untuk kita mau ekstubasi di ICU, mau berapa waktu atau respon pasiennya?
Saya kira tergantung dari klinis pasien, dokter. Yeah.
Okay, so Prof. Rath, there's question from Dr. Pandit. I might ask, what's the extubation consideration for pediatric population in neurotrauma settings, whether in the operating room or in the pediatric ICU?
Yeah, so you are talking about pediatric trauma patients. So if the child is having severe trauma, severe TBI. So in that case, we will have to continue with mechanical ventilation. In my talk also, I gave an example of EDH cases. If a child is coming with an extradural hematoma and the child is conscious, little bit drowsy maybe, and there is impending herniation. In that case, if you are taking up the child for surgery and after evacuation, the child should be fine. You will have to do the evacuation as soon as possible. So after that is being done, there is no need to continue with mechanical ventilation unless there is a requirement. So in those cases, those are the few cases where you can go ahead with extubating the child on table itself. This is what we practice since a long, and there is no problem with that. But as far as the severe head injury and moderate to severe head injury, obviously we'll have to continue with mechanical ventilation, and depending on the recovery of the child, as per the criteria set for extubation, that you will have to assess, and after that you go ahead with extubating the children.
Okay, thank you, Prof. Rath. Next question is from audiences online via Zoom from Dr. Andreas Willianto for Dr. Sudadi and Prof. Rath. What is the consideration to do early tracheostomy in pediatric severe brain injury? Thank you.
So usually we go for means depending on the case. If we assess that depending on the CT finding and the clinical parameters, if you assess that the child may require prolonged ventilation, in those cases we go ahead with early tracheostomy. Rest other borderline cases, obviously we just assess and go ahead with that. You see, tracheostomy is not for the sake of doing tracheostomy. It is another injury we are inflicting in the patient. So we should wait till we are sure about the risk-benefit ratio. If it is a prolonged ventilation required, obviously you assess with the imaging modalities and the neurological signs, and you are sure about there is a prolonged ventilation that is required for this child, then you go ahead with early tracheostomy. So we prepare early tracheostomy in those cases. But as I mentioned in my presentation as well, the incidence of severe TBI in pediatric age group is quite less. So if it is moderate and when you are in a situation where you are expecting that the child may improve, so in those cases you should wait and watch for some time.
Thank you, Prof. Rath. Dr. Sudadi.
Yes, ini penting sekali bagi kita untuk memahami ya. Jadi pada dewasa memang early tracheostomy ini secara evidence based akan memperpendek length of stay-nya ya, walaupun luaran secara gusi itu tidak terlalu jauh berbeda ya. Tetapi penting indikasinya harus jelas bahwa dengan prolong ventilasi mekanik ini menunjukkan suatu indikasi. Jadi penting kalau saja tidak terlalu jauh berbeda dengan dewasa bahwa pada prolong ventilasi mekanik mungkin early tracheostomy akan menjadi lebih baik. Ya, cuman kita bisa predik enggak untuk prolong mechanical ventilation-nya.
Okay, terima kasih. Thank you, Dr. Sudadi for the answer and Prof. Rath for the answer. Any other questions from this room, from audiences online? Yeah. Okay. So, if there's no other question, please give round of applause for Prof. Rath joining us from India and Dr. Sudadi joining us here. And please welcome all of our speaker, Prof. Ina and Prof. Yunita also. Okay. Penutupan. Let's join our seat here. Closing. For closing. So, before we close this agenda, I'll give each of our lecturer 1 or 2 minutes for closing statement for this lecture that been given. Maybe start from Prof. Ina, what we can do for the next.
Okay, thank you once again for the opportunity. So I like to emphasize, whenever you're, this is something that I think all trainees and even myself, whenever we attend a talk or a conference, you must look at the conference, at the content and say, how does that lecture change my practice? You either get out of this room taking back something that you want to change, something that you're going to stick to it, or something that you want to not do it anymore. Because only with that, you will then become a better anesthetist. So I think the content today are all very good, from Prof. Yunita, Dr. Sudade, Prof. Rath. And every time we attend any lecture, you need to do that so that they have all summarized all the clinical practice guidelines. There's no point going out from this room and say, oh, I'll just go to what I feel I want to do. There's no point. So it must be something that will change your practice, and you think if it's still good, maintain it. And if you think what you did before is not good, leave it because there's no evidence for it. Okay, and good luck to everyone.
Maybe I will speak in bahasa ya, because mungkin untuk semua, terutama residen ya, yang masih belajar, ini adalah kesempatan yang sangat bagus ya untuk bisa menanyakan tip-tip atau pengalaman ya, untuk sharing experience dari para pakar yang kita undang. Kemudian juga bisa banyak belajar, jadi Anda tidak perlu yang harus mulai scratch from the start from the scratch. Jadi ini adalah harus dimanfaatkan ya, makanya kemarin kita melakukan workshop dan lain-lain, jadi tidak hanya dari teori tapi juga kita melakukan. Nah itu saya pikir ini adalah suatu kesempatan yang sangat bagus ya, nanti untuk kedepannya nanti kita bisa dengan topik-topik yang lain ya. Itu saja mungkin. Terima kasih atas kehadiran semuanya, Dr. Pandit dan semuanya. Saya sangat senang sekali kalau kegiatan ini bisa dimanfaatkan banyak orang. Ya, terima kasih.
Terima kasih. Sebagai dokter, tentunya kita itu harus, ataupun kita itu punya kewajiban untuk mengupdate ilmu kita, ya, melalui simposium ataupun pertemuan-pertemuan seperti ini akan sangat membantu kita untuk mengupdate. Sama seperti yang disampaikan oleh Prof. Ina. Pada event-event seperti ini pasti akan ada informasi-informasi yang baru. Nah, ini perlu kita manfaatkan dengan sebaik-baiknya. Terima kasih.
Prof. Raj, any closing statement for us to close this agenda, Prof?
Yeah, means you wanted me to talk to the residents, trainees. Yeah, yeah. Hope to reach out to each one of them very soon. I will meet them in person. But then, what I experienced during my with you, that every time I used to go to the OR, I used to read about those cases. Ask myself these questions, that why this is the thing happening and how to manage it myself, before I used to ask my consultant. So that is how I used to manage, and I would suggest the same thing for you. Read all those things. Everything is there in the literature, be it in the textbooks, be it in the internet nowadays. Everything is there, and based on that, you just make up your mind how to manage that particular case. And before you do that, obviously you discuss with your consultant that this is what your plan is, and this is how you are going to do the case, and how you are different from your consultant, that also you must discuss. Based on that, there should be a consensus. The consultant should also guide you, and accordingly you manage the cases. So while doing this thing, you will find out at the end of the year, you will finish up all the cases and all the literature that is required, which you should read. So this is what I used to do. This is what I thought of sharing with you. Thank you.
And thank thank you for our lecture. For the next session, I'll give the time for the MC. Thank you.
Okay, thank you, doctors. Thank you for all the lecture that given to us. Thank you from Prof. Ina that come to Indonesia, especially to Jogja. Please enjoy the Jogja. And also Prof. Yunita that gave us opportunity to make this visiting professor make it great education, and also Dr. Sudadi to give us opportunity to make this happen. And finally, let us officially close today's for the visiting professor session. Thank you for all the participants and also our lecturer, our moderator.
We hope that you have gained a lot of valuable insight, and we look forward to seeing you next time. Thank you very much.
Akhirul kalam. Wassalamualaikum warahmatullahi wabarakatuh.
Thank you.
Recording stopped.